All right, so we are excited here at Class Research to discuss a few important topics today. We'll be having several different sessions this afternoon. And one of the first topics we're going to be talking about is autonomous coding. This is an area of interest for a lot of different health systems, large or small, really doesn't matter. Most of the health systems that we're working with are always looking for ways to either cover staffing issues, to ensure that they have revenue generation, they're decreasing their AR, they're looking to increase their coding potential, but they're looking to do this in a way that doesn't put an additional burden, either with time or with money, on the staffing that they have, the issues that they're going through. So we're going to talk about a little bit today is beyond the revenue and cost, specifically what is the human impact? What is the impact on personnel? What is the impact on those teams, both within and outside of the health systems themselves? So a couple of things to go over before we begin. Autonomous coding, what is it and what is it not? Just as importantly, autonomous coding is really a system designed to take the processes that up until now have been entirely humans in the loop, humans doing all the work, to extract from a documentation encounter, a clinical encounter, whether it's a nurse practitioner, a clinician, a nurse practitioner, and take that unstructured data and put it into a structured format. The real issue that we run into, however, is that this is a time-consuming process, and the training that's required and the amount of update and updating that goes through for these clinicians and for these specialists is pretty intense. During COVID, one of the major inflection points was the Great Resignation, which we're all familiar with. Obviously, a very big issue where people were not able to really find quality personnel across the board, across the spectrum. Healthcare is no different. In healthcare specifically, we had outsourced coding firms who were losing personnel to teams like Costco, actually. Because if you could go work at Costco, make $15 to $17 an hour and get free hot dogs, hey, that's a pretty good gig. And you don't have to worry about actually updating your skill set. So when you have that pressure, the Great Resignation, staffing challenges, and so on, plus you had the hot labor market, where it was very tight, very difficult to find those types of folks to fill those gaps, suddenly you say, okay, well, how do I actually make this work? How do I find those solutions? So autonomous coding is characterized by using cutting-edge, bleeding-edge technology and algorithms to chart rapidly and with high accuracy. That is the caveat. You need to have high accuracy, because if you do not have the decent accuracy, when you submit those claims for processing, CMS is going to reject it, your denials rate will go up, obviously your coding rate will go down. It's very, very important not just to have the work done, but to have the work done and to do it in a way that is very processed, high accuracy. So the coding engines, they do different types of coding engines currently, and it's not just ICD-10, it's not just ICD, it's also CPT codes, MIPS. How do you train a computer algorithm to really recognize that discharge means someone leaving a facility versus something coming out of the body? Because discharge can mean both things, and if you don't have the context, it can be a little difficult. So this is where it breaks down, when the algorithms don't work super well because they're not designed to think as humans think. So this is one of those issues that is still a hurdle for these autonomous coding firms to work on. There are various models about automation or auto-coding engines. Everyone is attacking this and approaching it from various different methodologies, whether it's a heuristic model analysis, you're using rules-based engines, or other types of engines. All of these have to do with two things, though, NLU and NLP, so natural language processing and natural language understanding. And those are very different, because processing is very different from understanding, as I just explained a moment ago. There's various tools and technologies, and this is what CLASS is trying to do right now. CLASS is trying to help the industry, not to dictate to the industry what is autonomous coding, but to help the industry decide that. We're going to be having a summit coming up in August of this year, and that summit is I'm very excited about myself, because the goal of this is to bring together providers, vendor groups, industry leaders, and try to identify what is autonomous coding, what methods and methodologies that are being utilized actually constitute that autonomous coding. One of the issues that you'll see here at HIMSS, actually, if you just look around, you'll see teams that will list things like AI, right? They'll use the term AI or append AI to the end of their name. So suddenly, a company that before was just Maverick is now Maverick AI, right? Rapid AI. And they keep appending those AIs and those autonomous monikers to their name. So when you're a provider organization, how do you really understand the differentiation between this is real AI, this is real autonomous, versus a screen scraping that we've had for 15 years? The answer is you don't know. And that's where CLASS is trying to help by identifying the different areas and models that are being used. So one of the questions we get a lot as this is really building out and the growth is happening, and there are a lot of vendors in this space, by the way, they're growing in this space. One of the questions I get is, what is CAC versus autonomous coding, right? Or is CAC a version of autonomous coding, or is autonomous coding an iteration from CAC? And the answer is no. No, yes, and no. So if you're paying attention to the order I shared those things, then you have your answers. But let me go back, for those of you that weren't with me on that. CAC is really just a tool designed to take unstructured data and try to extract the most salient types of codes for someone else to go and look at later, an outsourced coding firm, a specialist, to extract those codes. It does do some things that are analogous to autonomous coding, but autonomous coding takes it to the next level by actually utilizing those algorithms to identify those high-level areas that are important and extract them in the right order and the right way. Again, the goal here is to decrease the burnout. Let me pause here for just a quick second. So back when ICD-9 transitioned to ICD-10, that's when CAC came on the scene. And very similar to today, people in the CAC firms, some of which are here at the event we have today, so I'll try to talk quietly. They build this as the solution, computer assisted. It would solve a huge burden on the staffing, and it has done some of that. It has achieved those goals. But autonomous coding today is doing the very same thing. They're making the very same claims. They're trying to say, hey, this is going to reduce your staffing burden. It's going to take care of all your issues. You can repurpose staff, reallocate resources, and you can have better revenue. All the same claims that were made when ICD-10 came out in CAC. So here again, what class is trying to do is to shine a light on those areas and to share, okay, here's why this is not exactly the same as it was, and also here's where it may be different going forward. Historically, CFOs are a little reticent to trust AI and algorithms with something so important as human coding. Why? Because if you submit something to CMS or for billing or to a payer group and they see that you've overcharged, overcoded, it will massively impact you. It will actually, you can get on a blacklist, you can get on problem lists, and it can actually impact your ability to function as a health system. So CFOs are very, very careful about their process, and they want to know, is this real? Can it truly deliver? And will it deliver accuracy? That's the questions that we're trying to ask. So where can we apply autonomous coding? What areas can we apply this? The high coding outcomes that we're looking for, these issues, all the things we talked about, this is where it can be applied. If you're a large IDN with 40 hospitals and 30 clinics, you can utilize autonomous coding. The question is, you will need to apply it in only departments where it's currently live. Now, right now, KLAS has validated several autonomous coding solutions. And like I mentioned, we're going to have a summit in the fall, and we'll be going through this in more detail. But even of those teams that we have validated, we've only validated this in oncology, radiology, a few surgical, some pediatrics, and that's about it. So the reality of the situation is, what areas you're looking to deploy this in is really, really important. What areas and what departments you need to deploy this in will make a big difference. Yes, please. So great question. So the departments right now, oncology, radiology, pediatrics, some surgical, and then we are hearing claims of people being able to do things like working in areas beyond radiology, imaging. There's areas of imaging that is being utilized as well. Because when a radiologist is going through, right, and they're reading a chart, they're delineating, they're documenting the processes, it's actually using that to either use an ambient solution or a heuristic model solution to extract that and then to deliver some information that is actually helpful. So the goal of this, again, is to break this down. And this is the big issue right here, this word, silos. So any provider will tell you, if you get them drunk enough, they will tell you that there are silos at health systems, that their own health system probably has those separations and fiefdoms and silos. So how do we break those silos down and apply an autonomous coding solution across multiple different areas simultaneously? The answer is, you probably won't. And so the reality is we have to have multiple stakeholders, multiple internal people, all on board with the process, from a CMIO, CFO, the VP of Revenue Cycle, the Director of Business Officer Coding. All of these people have to work together to determine if this is a good application for their usage. One of the other areas that I wanted to talk about is, where is it deployed? We talked about this just really briefly, but let me double click on this for just a minute. Autonomous coding, again, has broad applications, but one of its Achilles heels, as it were, is it only can learn so fast. So picture autonomous coding engine like a toddler. I have a 5-year-old right now in my house. Not quite a toddler, but still, he keeps running into things constantly. And I love him, and I want to raise him right, and I want to help him, but the only way he's going to learn is through experience. The only way you really learn something, I can tell him all day, don't touch the hot stove, right? Don't touch the fireplace when it's on because it's going to be hot. It's going to burn you, Ethan. But until he actually does it himself and maybe gets a little burned, then he'll learn and he'll never forget that lesson. When it comes to autonomous coding, we're hearing some of the very same processes. So autonomous coding learns as it goes. And the very best autonomous coding firms, they actually go out there and they level set with the provider organization saying, look, you're not going to see immediate outcomes. This might take 6 to 9 months before you're truly developing enough revenue and you're truly seeing the appreciable outcomes that you were hoping to get. This is one of those areas where I think it really delineates between those who are prescriptively selling and applying on the vendor side and those who are over dramatic and hyperbolic and saying, this can solve everything for you, you're going to see immediate outcomes. And what's great about class, one of the things that I love about what we try to do is, again, to shine that light and to try to identify which vendors are over the top and over exaggerating and which vendors are really giving it the right perspective. You need to let it learn in order for it to really be effective. That's one of the major caveats of autonomous coding. So I didn't mention pathology, by the way. Pathology is another area, and ED is one of the areas we're looking at growing right now as a potential. I have not spoken with anyone and validated it in ED, but it is something that I know is very, very much in demand. One of the reasons why ED is so acute, or why the need is so acute, is because emergency departments have had the highest level of turnover for the majority, in terms of both clinicianal staff and nursing, of almost any other department in most health systems in the US over the last couple of years. And the reasons for that is clinician burnout has always been historically higher in ED. They're dealing with a higher volume of patients, trauma, very, very difficult situations. So ED tends to have a higher level of churn to begin with. And with the COVID pandemic and so on, it actually exacerbated that, made it worse. So we're hearing from a lot of health systems saying, we would really like to deploy this in our emergency department. Is that something that we can do? So again, the team that's able to pull that off, the vendor that's able to do that, I think will be the one who will be able to actually do some really neat things there. Where I feel and where I talk with providers, they feel would be also areas of deployment that would be extremely valuable. Women's health. Women's health is one of those areas that historically gets suborned to other areas, and it is not a point of focus. So women's health is an area, pediatrics, like I mentioned, obstetrics, cardiology, outpatient therapies is a big one as well, especially when you're dealing with an outpatient clinic where they're really set up to only do certain aspects of processing or certain aspects of healthcare. So outpatient therapy is another one, and gastroenterology. Gastroenterology is another one of those areas where it actually lends itself really well. The codes are all very generally similar, and they're not dichotomous. That's another word of the day for me. And so they are set up to actually take that information, and it's easy to code. So again, could be applied here. There's other specialities as well. Okay? Any thoughts or questions from the group? Okay. You all look really familiar for some reason. I'm seeing you somewhere before. Autonomous coding can impact revenue. Let's be honest. At the end of the day, when hospital revenues are down and staffing challenges are all around us, what really impacts the healthcare system? What really is it keeping up a CFO at night? It's going to be revenue. So how can autonomous coding impact revenue? A couple of different things. Number one, like I mentioned earlier, time to bill. Okay, time to bill. So the speed at which you're able to take that unstructured data and go right to bill, right? Going from anywhere from 3 to 4 days down to 1 hour, 6 hours is a material and massive impact in workflow and in cost. The quality of coding. So there are some of the early data that we were showing with autonomous engines actually show that humans make mistakes, machines don't make mistakes, they make errors. Now, why is that a difference? Because humans will do something based on a lapse of knowledge or information or a knowledge gap. Machines do it make an error because they're programmed incorrectly. And over time, those errors can diminish, again, if they learn over time as a process volumes of data. So the quality of coding has to be there, and the overall volume. Again, volume is the key. I spoke with the health system just a couple of weeks ago, and the director of business office was effectively telling me, she said, look, I have an issue right now where I cannot hire coders for even up to $32 an hour, plus full-time benefits and so on. So their backlog is now building up. They have charts that have to be coded. They have to be done. And they have to be done by law within a certain period of time. So if they're not getting that coding done properly and within a timely manner, that is a material outcome negative. So this is where autonomous coding is an opportunity to help with that. Time to scale. This is something that's absolutely essential with autonomous coding. Not every vendor has proven this to us yet, even those that we've currently measured. So one of the things that we're looking to do at class is build out our reporting on this area, talk more about it, and look at time to scale, meaning you can do really well with a 25 doc practice that you're coding, you're handling their volume well. Now what happens when you go to HCA, or when you go to Advent, or when you go to a major IDN or network? Can you actually develop that and have the ability to scale to that level? Now you would think, well, it's a computer program, right? It's a model, but it's a program, it's an algorithm. It should be absolutely scalable. It's not like we have to go hire a bunch of people, train those people, get that cohort in the field, and actually go out and code. But the reality is, again, not all companies have the ability to understand the vagaries of healthcare, meaning what? If you've got 2 or 3 hospitals that are running on Meditech, and you got 3 other hospitals that are running on Epic, and you got some outpatient clinics that are still on Athena, none of those EHRs really communicate as well as we would like. None of them are on the same processes. So how do we actually overcome those gaps? That is a question that we're still going to be asking. Most coding solutions take a lot of time to see this. That's, I mentioned earlier, the best vendors and the best teams are the ones who are actually going out there and saying, hey, let's be realistic about the outcomes, how long it's going to take for us to achieve these outcomes, because it's not going to be right away. The longer the engine has to train, the better. And this is something really interesting. We at class see something called the new implementation smile, right? Where things do really, really well, they drop down for a little while, after post-implementation, and then eventually the bugs get worked out and it comes back up again and it does well again, generally. With autonomous coding, we're actually seeing the obverse, meaning we're seeing kind of okay outcomes to begin with, but then over time, it exponentially, not incrementally, exponentially gets better. This is something that's really unique to autonomous coding, and it has to do, again, with all the processes we talked about, the engine learning, and so on and so forth. All right, staffing. If anybody, I would love to see if we could do like a poll of some kind here at HIMSS and say, what is your top issue as a health system provider that you're looking to solve? I would guess revenue would be probably number 1, generation of revenue, and then staffing shortages and amelioration. That would be number 2. So when we look at these different systems, the early retirement, we have a lot of folks who are leaving the medical profession for various reasons. Again, the COVID pandemic accelerated some of that. So this is one of the major issues. And it's important to note, which is why I said it's important to note on the screen, just making that point there, that it's important to note that no autonomous solution is truly autonomous, meaning no humans in the loop. That's a major differentiation, because if you can say, well, this coding engine takes all the data and goes direct to bill, excellent. But the reality is we have not yet validated any solution that can do that 100%. 85%, 90%, yes, but not to 100%. And that is an important distinction. All right. Human impact. There we go. Look at that. Right on time, almost. Well, there, Tiffany. All right, we refer to autonomous coding with the moniker autonomous, but again, the promise and peril of artificial intelligence continues to be a part of the broader conversation within healthcare. I cannot stress this enough. And like I mentioned earlier, AI is a term that's been bandied about so much that I think it's lost all meaning, candidly. I was on a phone with a CFO in October of last year, and I brought something up and I mentioned AI, and she literally put her head in her hands like this and said, if I hear AI one more time, I'm going to lose it. Like, this is the frustration. When you take a term, and I worry we're careening dangerously close to this with autonomous coding, the moniker autonomous is really losing its meaning. It's losing its value, and it's not really super helpful to people who are trying to figure out what's real about this and what's not. There is significant information that proves clinician burnout is one of the main drivers of revenue. So it's not just keeping people happy, it's keeping people at my health system. It's making sure that my clinician that costs $1 million to replace, if I can keep that clinician and do it with some solution that helps decrease burnout, that's worth an investment in another vendor solution or another opportunity. So whether you're a provider that's large or small, these same metrics apply, and the same tools will apply for that. All right, any thoughts or questions from the group? Yes, please. Excellent question. So for those of you who couldn't hear Emily's wonderful question, so what are these standalone facilities? What departments are they being deployed in? But then also what types of facilities? What types of groups? It's all over the place right now. I will say that primarily today, the teams that we have engaged with and currently measure, they're primarily in the large inpatient space and against those departments we talked about. So again, radiology, oncology, PD, ED a little bit, surgical, some of those areas. Pathology is another one. But it's primarily the large inpatient. Why? Because the sheer volume of chart coding and issues is substantially larger in those large systems. But they're also, and this is what's really interesting, they're also the most difficult to code, right? They're the most difficult, the most complicated. Pediatrics, you could see a patient one day with presenting 6 different types of symptoms that are totally different from the next patient, right? Whereas with oncology, it's always pretty much the same codes that are being extracted. So there are departments and areas that are easier to code, that are probably more rapid or earlier adopter. It's a little bit like with ChatGPT, where if anybody here has used ChatGPT, you can admit it, it's okay, it's all right, it's a safe space. ChatGPT is a really good tool, but in my humble opinion, it will never actually replace people, right? I actually asked, there was a friend of mine who's a computer science, and I asked him, I said, do you feel like this is going to replace people at some point? His response was, no, but the people who do not utilize these tools will be replaced. And I thought that was a really interesting distinction. It's not that the tools can fully replace the people, but if people do not adopt them, and by Yes. Oh man. Okay. This is what keeps me up at night. This global warming, climate change, and I have 2 rabbits that keep escaping from our hutch. Those are the 3 things keep me up at night. So top of the list there, though, for me is exactly what you're describing, Mike. So how do the providers really know what's behind the scenes of that? And again, that post-implementation and the time that it takes to really see an appreciable impact, it's hard to, you can see the impact, but again, can you really see the true outcome? Are they coding at 90%? Are they coding at 80%? Is there humans in the loop? This is a concern. Please. Oh, excellent. So we have teams like 3M, for example. They are, but they also are not, right? So they have code right and they have some solutions, but they're not fully deployed, meaning we actually haven't talked with anybody saying, yeah, we're using 3M for auto coding. 3M is talking about it, they have a solution, but they're not fully to market with it today. And there's a couple of teams. Akasa is another one. I don't know if you've heard of Akasa. Akasa is another one that actually is very interesting because, again, they're an AI solution tool, but they're like, we can just simply apply our heuristic model to coding. And they just plunk it on top, and they are getting some outcomes. Are they really beneficial outcomes? Yeah, it depends on what you're looking for. Exactly right. Which, again, in coding, we've always had that, right? We always have to have an auditing, right, going on the process. So for a lot of providers, they're like, it's just like that, except it's a lower cost solution. We can take some of our in-house people, reallocate them, which saves us money, right? And we're already going to have somebody auditing it anyway. We'll bring in SciOx or somebody else to come in and audit it and do that. Excellent question. All right, I think we're up at my time. So thank you all for coming. Really appreciate sharing this today about autonomous coding, and look forward to you having a great HIMSS. Thanks, everybody.